welcome back to Night Nurse, my lovers of learning. I'm Professor Burns, and today we're going to talk all about immunodeficiency. So, immunodeficiency is a partial or total loss of a portion of all the immune system, and we can think of it in terms of primary or congenital developmental failure, and this is when we have decreased function prior to birth. The most common is hypogammaglobulinemia. When you look at the word immunoglobulin, which is antibody, you can see that it means globulin, which is a protein of immunity. So it just means a protein of immunity. So those all come from gamma globulin. So if a patient has a genetic defect of the inability to make gamma globulin, then they can often be born with the condition where they can't create very many B-cell immunoglobulins, and they'll have primary or congenital immunodeficiency. We can also get low bone marrow productivity or low thymus productivity. This would result in decreased adaptive immunity. Usually we're talking about acquired or secondary immunodeficiencies, and these are ones that are acquired through procedures or most often through diseases. Some examples of this are a splenectomy. Someone has some sort of traumatic event, or even patients who have sickle cell disease. They often have to have their spleen removed, and it's lymphoid tissue, so that can result in some acquired secondary immunodeficiency. Malnutrition or liver disease reduces the amount of protein that can be made, and that will lower immunoglobulins. Immunosuppressive drugs such as chemotherapy or radiations or immunomodulators, long-term corticosteroid use, these all suppress the immune system. And viral illnesses, there are some viruses that can result in decreased immunity from the disease. So one such example is HIV/AIDS, and that's where we'll spend most of our discussion. Complications of all immunodeficiency, mainly what the first sentinel sign of immunodeficiency can often be is an opportunistic infection. Now, an opportunistic infection is when the infection of an organism that really should have never happened, the body should be able to defend against that infection. So, such fungal infections or infections from usually benign bacteria, like Pneumocystis carinii, also known as Pneumocystis jirovecii. So if someone comes in and they have a pneumonia and it's cultured and it's found to have Pneumocystis carinii, then you kind of go, well, wait a second. You're supposed to be able to handle Pneumocystis carinii. It's just normal flora floating around. So it often prompts further investigation. So AIDS, or acquired immunodeficiency syndrome, remember we talked about syndromes being a constellation of signs and symptoms that point to a certain diagnosis. So there is the breakdown of the HIV virus, and that is the beginning of HIV/AIDS. First, we have infection with the HIV1 immunodeficiency virus. The HIV virus is an RNA retrovirus that infects T helper cells of the host cell. So those are the T helper CD4 cells. HIV is a retrovirus, which means it goes backwards. Normally, we have DNA that makes messenger RNA. The messenger RNA then forms proteins and spits those things out, and that's how we get a production of something. A retrovirus means that it goes from virus and it creates messenger RNA, mRNA, and incorporates that into the host's RNA or DNA, so that then the host cell sneakily, accidentally makes virus. And that's what the HIV virus does. When someone has HIV positive status, it means that the body has made the specific lymphocyte antibodies to the virus. So they're HIV positive. It does not mean they have AIDS yet. HIV virus itself doesn't really cause very much harm. It might cause a couple days of cold symptoms. The problem occurs when we go beyond HIV and it develops AIDS. A patient can be HIV positive for months or years or forever. And it's not really fully understood why some people fully convert to AIDS and other patients can remain HIV positive for virtually forever. So AIDS is when we have viral replication through the HIV protease and we get a high viral load of HIV virus, and that infects many, many more cells. So the way you can think of it is you have a T cell. It's infected. When you reach a certain point of a high number of T cells being infected, just like in any situation, cells infected, so this is going to activate what? It's going to activate cell-mediated immunity, and you're going to wake up specific immunity and cause T cell proliferation. That is cell-mediated immunity. So now this little ninja T cell is going to come over and it's going to wipe out the cell that's infected. No big deal, right? T cells attack the infected cells. Boom. Fall down, go boom. It's dead. Killer T cells begin destroying the HIV-infected cells by inducing apoptosis. That is exactly what you would think of if you have a cold or anything else, is that T cells would come in and they'd destroy an infected cell. So it's no big deal. But AIDS is special. The problem is HIV infects our T helper cells, our CD4 architects of immunity. This causes a big problem. The T cells, in essence, assassinate their very own CD4 T helper cell architect, and this destroys nonspecific and specific immunity. CD4 T helper cells coordinate B, T, and macrophage nonspecific inflammation phagocytosis immunity. So it's a big problem because the destruction of the T helper cell destroys both nonspecific inflammation and specific B and T immunity. This results in our acquired immunodeficiency syndrome, known as AIDS. So what are some manifestations of AIDS? Well, we have some diagnostic tests. First up, in the blood, what makes you HIV positive? That's where the detection of the P24 capsid protein antibody for HIV, and it's confirmed with Western blot. That's what makes you HIV positive. So normally people are running along, and you see here on this graph that you have normal CD4 cells along the top. Those are your T helpers. They're moving along. They're doing just fine. At the very bottom, you have viral load. So you had an initial seroconversion that had a little bump, but otherwise, viral load remains pretty stable. And the patient is making more and more antibodies. So far, so good. But what happens is at a certain point in time, when we get active disease, converting from HIV positive to AIDS, is that CD4 T helpers begin to get destroyed. We get this ninja coming in and wiping out the CD4 T helper cells. So they begin to plummet, and when they begin to plummet, the viral load begins to go up. So low CD4 titers, that initiates, that is an indicator of active disease. And this is a problem. So AIDS diagnosis can actually be made with three components. First, HIV positive. Second, CD4 T helper cells less than 200, plus an opportunistic infection. So often the patient will come in and you'll learn these in the opposite order, right? Patient comes in, they have a pneumonia, they culture it, and they're like, hey, noticed you have pneumocystis carinii. That's a little concerning. That's considered an opportunistic infection. You should be able to handle that. So then they do some lab work. They talk to the patient and everything. They do some lab work and they check the T helper level and they notice that CD4 titer is less than 200. And they're like, whoa, what can cause that? So then they check the patient. If they don't already know, they check the patient for their HIV status. So HIV positive, plus CD4 titer less than 200, plus an opportunistic infection, that is the syndrome of AIDS. Other signs and symptoms of AIDS, it's systemic. right? It's all over the body. So in the blood, we have that high HIV viral load, we have low CD4 counts, and we have low white blood cells. Immunity is down. Opportunistic infections, Pneumocystis jirovecii, also known as Pneumocystis carinii. We have mycoplasma pneumonia. Normally, our body can handle mycoplasma, so if someone has a mycoplasma pneumonia, that's an opportunistic infection. The breakout of herpes simplex virus, GI, we can get oral yeast, oral herpes outbreaks, like cold sores, diarrhea, abdominal pain, muscle wasting. On the skin, they can get different dermatological staph infections. They can also develop Kaposi sarcoma, which is what you see on the foot to the far right. It's like purplish, bloody, almost look like blisters, but it's actually a form of a sarcoma. Generalized lymphadenopathy, because the body's trying to do what it can to fight infection, and that's swollen and tender lymph nodes. Neurologically, they can develop dementia, memory loss. They can get HIV infections, toxoplasmosis. Good friend of mine went to high school with. That's actually what a herpes virus. He was HIV positive, developed AIDS, and actually what caused his demise is a herpes simplex virus infection in his brain, and it caused dementia. I mean, the guy was like 45. So it can affect multiple different areas if it wants to. Okay, so that's a breakdown of immunodeficiency and AIDS. So hopefully you found that helpful and enjoyed it. If you did, please sure to subscribe to the Night Nurse Learning Channel, and also be sure to visit nightnurse.com, where I'm always trying to add new content and help you guys out as best I can. I appreciate you, and see you next time.